electrophysiologist. I will continue directly to the topic of the idiopathic ventricular arrhythmia, distribution of the origin, diagnostic algorithm, and ablation strategies. I have nothing to disclose. And when we deal with the patient with ventricular arrhythmia, the first thing that we have to look at is whether the patient have a normal structural heart disease or actually he or she have underlying structural heart disease. For the one who have normal structural heart disease, the two possibility of the ventricular arrhythmia. First is the idiopathic VT or idiopathic ventricular arrhythmia, and secondly, primary arrhythmic syndrome. Well, for the patient with underlying structural heart disease, it could be an ischemic cardiomyopathy or non-ischemic cardiomyopathy. And for the idiopathic VT, there are several types of idiopathic VT, octotract VT, fascicular and crux VT, and also papillary muscle VT, while others shown in this list. Today, we would like to discuss primarily on the idiopathic VT. And as we know that the mechanism of arrhythmia could be divided into three: automaticity, trigger activity, and re-entry. And among those idiopathic ventricular arrhythmia, these are the list of the mechanism. This left side is basically caused by the enhanced automaticity or trigger activity, while the only re-entrant mechanism in idiopathic VT that is known as verapamil sensitive ILVT or idiopathic left ventricular tachycardia. Now we will look at the distribution of the origin of ventricular arrhythmia. In this paper beautifully shows us the origin of idiopathic ventricular arrhythmia in both the right ventricle and also the left ventricle. In the right ventricle, majority are from the right ventricular octotract, and then also a few percent in the right ventricular free wall, while in the left ventricle we could find in the mitral annulus or the fascicular or ILVT, and also papillary muscle, and also some of them from coronary cusp. In general, the percentage of RV tachycardia is more than 50%, while the left around 38%, and the remain probably only 10% RV cardiac VT came from the great cardiac vein or middle cardiac vein or AIV. So now let's learn how to identify the origin of the ventricular arrhythmia. The first is the morphology in the V1, as Dr. Raharjo have mentioned deeply, but I would like to, as Dr. Raharjo mentioned, to simplify that if you have the ventricular arrhythmia with left bundle branch morphology, which show here in the V1 have a QS pattern, then it means that the origin from the right side goes to the left side. While if you have the right bundle branch morphology, if you look at here, the V1 is R pattern, and the possibility that the origin of this ventricular arrhythmia is from the left ventricle. Secondly, the algorithm that I preference use is this one. In the lead inferior lead, if you have positive in the inferior lead, probably the VT or the ventricular arrhythmia are from the superior aspect of the ventricle. And vice versa, if it is negative, probably from the inferior aspect of the ventricle. And regarding the basal on the apex, we could see in the precordial transition, if we look at like this, positive concordant, most likely this is from the basal. And one of the parameters is the V5 and V6. If those are positive, probably from the basal, and vice versa. If it is negative, then probably from the atypical. And now, those are the general concept. And then let's check one by one the idiopathic ventricular arrhythmia. The first is the outflow-tract ventricular tachycardia. This is a subgroup of idiopathic VT that are predominantly localized and around the right and left ventricular outflow tract. And certain triggers cause intracellular calcium release, causing the delay after depolarization. And we don't know why, but this is more commonly found in female patients. These are the locations on the side of the common ventricular arrhythmia from outflow tract. Look at here from the sagittal view. This is the anterior aspect, yeah, and this is the posterior aspect. This is the coronal view. You can see this anterior aspect is the right ventricular outflow tract, while the posterior one is the left ventricular outflow tract. And these are the common location of the ventricular arrhythmia. One of the simple way to identify the possible location we could see in the V1 pattern. If look at this like QS, most likely, yeah, of course, there are many other parameters that we will see later on, but probably from the most anterior aspect of the ventricle. And if you look at V1 posterior like this, probably in the most posterior aspect of the ventricle. Then if we look at this, the frontal plane axis this is from the left one, and from the right side to the left side, you can see that this is from the QS become more positive. And all of these outflow tract ventricular arrhythmia have positive in the inferior lead, showing that it is from the superior aspect of the ventricle, could be from the right or from the left. These are the general concept for algorithm to identify the possible origin. But many researchers, many investigators have developed an algorithm to precisely identify the location so that when you do ablations, or when you send the patient for the ablations, you could predict whether the location is the right side or the left side of the ventricle. One of the famous one is the Penske score, published in JACC 2011. They use V3 transitions between V2 transition between the PVC and the sinus rhythm. So you divided the amplitude of the PVC with the amplitude of the sinus beat. If the transition, the ratio is more than 0.6, probably this is from the left ventricle of the tract. And also, this is another algorithm, the transitional zone TZ index. You also could see this is could be used for identifying the left or right ventricle of the tract. And also, this is the V2S and V3R index. And if we look at the original paper published in 2014, this data show that the sensitivity is quite good, 89%, and the specificity also quite good, 94%. But when other investigators try to validate this data, what they found is quite different. So for example, these V2S and V3R index, the sensitivity is only 67%. Much lower compared to the previous or original paper. So it is interesting that in 2018, Dr. Korsunov published in EP Europace 2018, they didn't use the ECG algorithm to help to identify the possible location or possible origin of the ventricular arrhythmia, but they used the CT image. And when they found that bigger the orthopulmonary valvular planar angulations, show the possible origin from the left side of the ventricle or from the LVOT. And they show that this have a good ROC curve and have a significant uh, predictions when they have a multivariate analysis. But we know that doing CT image about take the CT for the patient who will do ablation is quite troublesome. So we try to modify that image using the echocardiography. So we developed kind of new uh, new way, new approach to identify whether the location of those PVC are from RVOT or from the LVOT. And we develop auto-settle angulations by echocardiography to predict the origin of the autotract ventricular arrhythmia. And this is the way we do. If you take the echo from the plex parasternal long axis view, you could have this angle between the septum and the aorta. We try several cases that if we have the LV right ventricular outflow tract, the angle is getting steeper. But when we have the PVC from the LVOT, uh, it seems that the angle is smaller. So we tested this observation with the study, and we found that using the cut of 129, we could predict more that the PVC location probably from the LVOT. And we did the multivariate analysis, and this is quite good predictions. Now we are in the validating period of this data. So yeah, this is one of the approach to identify the location of the autotract ventricular arrhythmia. I'd like to share some case of patient with PVC that we did ablations. If you look at this is a gentleman, 49 years old, with palpitation. If you look at this PVC frequency is quite low, less than 1%. But this patient is really symptomatic. And when we try to see in the guideline, although it is mentioned that in the first place, we should have the frequent and symptomatic PVC, but actually, if the patient also, even if infrequent but symptomatic ventricular arrhythmia, this is one of the class 1 indication for catheter ablations. And we look at this, at the percentage of recurrence. When you do ablation is more than 80%, but when you do only medical therapy is only 10 or 20%. And the success rate for RVOT is more than 90%. Coming back to the patients, when we look at the Holter, unfortunately, the Holter only have 3 leads. And based on this infrequent PVC, the 3 lead in PVC, we could see that there is a different morphology. And also the episode of the non-sustained VT, this is negative. This is one of the problem when we do PVC ablations. So we use this approach to induce the PVC. And using this, we initially use isopren, bolus isopren, but still the patient still has no PVC. So very difficult. And then we use epinephrine, 5 to 10 microgram injections. And we could see a single PVC initially. So like this. But then only another infrequent PVC, and then in total we have 3 PVC morphology. But it is very difficult to do activation mapping for mapping this ventricular arrhythmia. So then we do this voltage map, kind of normal. And with this turbo map as inside precision property, we could identify the possible location after the map on the geometry has been developed. So like this, so we just use the first PVC, the second PVC, and the third PVC. and then we could localize the possible location. And then after that, we induce again with the epinephrine. We could see that this have a very good LAT in these three locations. And also the pace map or score map also have a good 99%, 98%. And we did the ablation, and then the patient free from the PVC. Now, this is one of the way to identify, to map the PVC symptomatic but infrequent. Another challenge for the upper tract PVC ablation is the LV summit PVC. Probably later on, Dr. Patak will present this more thoroughly, so I will just briefly mention about this. This paper shows that when you have the PVC with this abrupt V3 like this, or pattern break in V2, so this is higher R compared to the V2, probably those are LV summit PVC. This is one of the examples that we have. So this is like V3 abrupt R. And yeah, as you see, we also calculate this index, and the possibility of the LV summit is quite high. And we use this mapping. This is in the RPOT, and then the GCV, and the left coronary cast. And then finally, we successfully update the PVC using those. But in our country, I don't know, in India, the reimbursements from the health insurance is not sufficient to do 3D ablations. I don't know, in India. So we have to think how to manage the patient with LV summit PVC using the conventional approach. This is another patient that cannot be covered by insurance. So we try to map using the conventional approach only. And look at this RVOT, also we use only the activation mapping. And this is the left coronary cast, and this is the grid cardiac pain. So even if we only use the fluoroscopy and activation mapping, we could successfully ablate this LV summit PVC in these patients. Next will be fascicular and crux VT. So briefly, we have to mention that the fascicular VT or ILVT have the right bundle branch block morphology, and majority have a LAD from the posterior fascicle of left ventricle. And what we do is to map this Purkinje potential. And for the crux ventricular arrhythmia, usually they have this kind of left superior axis and V2 R. V2, the R is more than the S wave. And for the apical crux, of course, you have to see the V6 and the V1. This is the diagnostic algorithm, and some persons use this approach to update the crux PVC of ventricular arrhythmia. So they go to the mid cardiac vein and update in there. But we have another approach that by combining the left mapping and the right ventricle mapping, and we could identify in the left ventricle, this is in the right ventricle. It is not quite early, but for this crux PVC, the best thing that we can do to update is both the right ventricle and the left ventricle approach. And the next is, this is another very difficult case of papillary muscle VT. The morphology is similar with the ILVT, but have a wider KRS complex. So right bundle branch morphology and superior axis. And this is conventional method use this kind of mapping and identifying this potential. This is slightly different with the fascicular signal. This is a fascicular signal, while this is the papillary muscle signal. Yeah, this signal, and we update there. But when this during the ablation, we have seen that the morphology are changing. Like this one, you can see in this, the green one have a higher R wave compared to the yellow PVC. So this is interchangeable between the one PVC and another one. And on we try to see the, sorry, this is as has been mentioned by Dr. Abhishek about the use of cartosan. Sorry, the video doesn't work. But finally, if we use this cartosan and then we identify the location, actually the first PVC is coming from here and the second one is coming from here, from the same tube of the papillary muscle. And the ablations also can be done using this mapping of this PVC from the tube of the papillary muscles. So in conclusion, ECG diagnosis for idiopathic VT is challenging, and the interpretation of ECG morphology provide information and prediction of ventricular arrhythmia or decay, especially for idiopathic arrhythmia. The common rule is like this is a left bundle branch or right bundle branch block or inferior axis or superior axis, and the components intercorrelate. And outflow tract VT is the most common form of idiopathic VT. Thank you, Dr. Wali, and all of the audience.
Thank you, Sunu. Regarding your question about like insurance in India, the electrophysiology devices, pacemaker, some basic ICDs are covered in insurance. There are two types of insurance in India. One is private insurance, which cover everything according to your limit, and there's public insurance. Public insurance at present, there is a scheme known as Ayushman Bharat scheme. In fact, like it tends to cover most of the poor population of India. So, frankly speaking, it is quoted as the world's most largest public health insurance, but the population of India is around 130 crores. So like they give them the basic pacemakers, some part of ICD, not the CRTD and other combo devices are not covered in that. So for the electrophysiology procedures, basic electrophysiology procedures are covered, but like if we use ICE, 3D mapping, some high-end catheters, cryoablations, and then that is out of their payment limit in the national insurance. So this hinders us to liberally use all the technologies for these patients, but like whatever way we can like find a way to help them and safely do the procedures, like we tend to do. So
yeah, but the 3D ablation cannot be fully
3D
covered by
ablation,
insurance.
like they have the Ayushman Bharat has a limit of say 5 lakhs for the family. So it will cover over a period, some period for 5 lakhs. So whatever goes above that limit, it will not cover. So the leads, AV and arteries, pathways, and all that will be ablated in 2D only. If you want to do AF and VT, we need 3D. So it may partially covered, partially the patient has to pay. So it is something like that. So if we use ICE, the expenditure goes up 50 to 1,000 to 1 lakh more. So, but still, I think because like the population of India is so huge, even covering for the basics, I think I think it is a great it's, like what a government can do. So in countries like Taiwan or Germany, the population is less. So there they have national insurance which will cover practically everything. You can use, I think, all the latest equipments and all that. In US, I think they might be covering all everything like ICE and all that, cryoablation. But I think in some other countries also, I asked that they were not using ICE because they say it is not covered in their insurance and there was some restrictions.
Yeah, that's our problem. So we have to find another
That's
approach.
but India also has a lot of patients. So, as compared to other countries, I think here the patients are also too much for a single doctor to see. I think patient-doctor ratio is also high.
I think it is just amazing how much work all of you are doing, despite some of the challenges, are there. And I think really congratulations and kudos to all of you for doing some amazing, amazing work. Certainly, having all these fancy technology helps. It is like you want to go in an air-conditioned car with self-driving features, or you want to go from point A to point B and get the work done and get the journey completed. Certainly, there are different ways of doing it. Certainly, if you have a nicer car that's more comfortable for you, the journey is more pleasant, the safety features are more. But certainly to get job done, what experience you guys have is just unbelievable. And I don't think I can do what you are doing, but certainly you can do what I do with your eyes closed. So I think it is more testament for your talent and skills.
Thank you. Well, actually, I think, thank you, Dr. Walia and Dr. Abhishek. I think we have many similarities between India and Indonesia in terms of the socio-economic part. So if we could continue this networking with the further kind of research or collaboration would be nice, I think. And also with the help of
Also, I find there is some epidemiological difference also between the same rhythm disorders which are there in India as compared to US or when we go to China or other countries. So some things which are very prevalent in US, I don't find the incidence is so high here. Or some disorders which will be very prevalent, say in Indonesia, you might be seeing very commonly. So I don't see here even in 2-3 years. So I think it's like multiple centers all over the world and epidemiological studies and all that. I think we can plan and in future and also look together to collaborate.
So Dr. Sunu, I had one question for you. You showed this very nice RVOT PVC case, which you ablated, and you had 2 or 3 different morphologies, on the Holter, what you had shown, the lead one was a little bit different. Sometimes it was QS, sometimes it was RSR pattern. So, and based on your map, do you think you're above the pulmonic valve? It just seemed to me that way by the morphology. I know you probably didn't have intracardiac echo, but just by your assessment on fluoroscopy and everything.
Yeah. Thank you, Dr. Abhishek. I don't think it is about the pulmonary valve. So 2 of them, the origin were from the posterior of the RTOT, and another one which showed the non-sustained VT in the Holter monitor, the lead, negative lead. It is from the anterior part of the RTOT.
Okay.
So
just one trick sometimes to use is that when you advance the catheter up from the RVOT, if you lose the signal completely and you're making contact, then you're definitely above the pulmonic valve because there is no myocardium there to make that signal. Because as you go higher and higher in the RVOT, you'll get pulmonary valve, so you'll get ventricular signals till all that area. As you go above the pulmonic valve, you will have these sleeves of 1 to 2 centimeters. And beyond that, you will not have this muscle sleeve. So you won't get any near field signal. So once you know that, then you know you're clearly above and way above the pulmonic valve. Then if you're anterior, you're not going to get any far field atrial signal. But if you are posterior, you are going to get a far field atrial signal because you're going to get far field area from the left atrial appendage. So that could be some of the clues you can have if you don't have intracardiac echo. Are you above and below the valve? And then are you very anterior or very posterior, depending on what you're seeing? And just for people who are listening, if you get a far field atrial signal above the valve, do not ablate there without doing a coronary angiogram, because if you have a far field atrial signal, that tells you you're close to the left atrial appendage, so you're getting that far field signal. But beyond that, you are very close to the left main. In one of the pictures I showed you, you can ablate the left main above the pulmonic valve. But a clue to realize would be if you see a far field atrial signal, that would be your marker in your mind that you should absolutely not ablate there.
Okay. So Yeah, I will notice that. So what is your approach when we have infrequent PVC, but very symptomatic, and then during the procedure, we cannot see. It is difficult to map by activation mapping. What is your approach?
So my approach really starts from the history of the patient. I ask them, do you feel the PVC is more during day or more during night? Is it more during activity or more during rest or sleeping? So that you can know from the Holter monitor, because you can see the PVC trend. If the PVC trend is more when the patient is active, then I know the isopril, all those things are going to work. If I see that the PVC trend is more during sleeping or when they are at middle of the night and then they wake up with palpitations, then I know maybe even sedation, when they sleep, the autonomic tone goes down, then maybe you may start to see these PVCs. Other thing I ask them, like, what brings it on? Is it any environmental stimulation? Is it coffee? You can give IV caffeine. Is it for young women? Is it menstrual cycles? Because it is very common that it is the PVC burden is higher during ovulation or just before or during menstruation. So maybe get a Holter around that time, confirm the burden, and maybe schedule the ablation at that time so that you can have the
Oh,
maximum yield of PVCs. That's one trick I use. And so this
thank
is
you.
on the history part. Then I also, when they come to the lab, main thing sometimes why the PVCs go away, patient is very, very anxious, coming to the lab. So the sympathetic drive is high, it can suppress these
Yeah.
PVCs. So try to keep them as relaxed as possible. Then as the outline you showed, like isopril, caffeine, even phenylephrine can help. Some exercise on the table itself can help to bring out some PVCs. But sometimes I've had few cases where you do everything possible and you had PVC burden of 40% the day before on a Holter. Next day there are no PVCs. Then you just tell the patient, we can't do it today, but we can bring you back and do it some other time. And then just keep like some time available, that if this patient calls and says he's having a lot of PVCs, then again you can plan the procedure around that time. But it is not infrequent that in a case you don't see any PVCs. Now certainly pace mapping can help, but pace mapping again for people who are just starting out is what we are doing here is, say this is the tissue and we put the ablation catheter here and we are pacing from here. So it will make a QRS like this. But in this outflow tract, what we talked about, you have your RVOT, you have your LVOT, and these areas are very close to each other. So if you pace from here, or if you pace from somewhere here, you can capture this area, you can capture this area, you can capture this area, you can capture this area. So it is not always perfect that you are going to get the most perfect pace map sometimes, and that certainly has some limitations while doing pace mapping. So I think the success for these procedures is really depend on good activation mapping. If you find a great signal like some of the signals what you showed, and if you have that, and that's going to be paramount. But again, just have a very honest conversation that maybe we may just not be able to do it that day and bring the patient back and do it some other time.
Thank you. Thank you. Well noted, Dr. Raharjo.
So I think we can go on to the next presentation, which Indonesian atrial fibrillation registry, and learn about what exactly was the results in valvular and non-valvular AF. Yeah, Sunu, over to you.
Okay. Okay. Again, thank you, Dr. Walia. And probably the second topic will be shorter compared to the previous one, because I would like to share some of the, just to share some of